webinar is going to be about. So you can see the agenda. I'm not going to waste any more time. I'm going to bring up Bob Aicher, who needs no introduction, but our in-house legal counsel. And Bob is going to just give some brief comments on questions he's getting with regard to the financial stuff that we've talked about, but also a legal update and a consent that we've recently put out that Bob has written for us. So Bob, thanks again.
Yeah, hey, I've just got 3 things to say today. Number 1, yes, the PPP program got another infusion of another $349 billion, or excuse me, $310 billion. You know, but they ran through the first 349 only 13 days. They already have a backlog of applications that didn't get funded on the first round. So to try and make it a little more fair, today at from 4 p.m. until midnight Eastern, Small Business Administration is only accepting loans from lenders that have less than $1 billion in assets. Okay, Wells Fargo, Bank of America, take a bow for a moment here. And they're claiming that loans in excess of $2 million are going to be audited. Okay, well, whatever. I think the bottom line is that if you aren't already in the queue, the money will likely be exhausted by the time you show up. Number 2, we went ahead and put out a COVID-19 informed consent agreement for your patients. I happen to agree with the doctor's company that this isn't a silver bullet. Even if the patients accept the risk, they are, informed consent and accept the risk of COVID-19, that doesn't mean that they can't still sue you. I mean, how many of you have informed consent documents covering the very thing that a patient filed for? But it is a great patient education tool because it goes ahead and makes patients partners in not bringing in COVID-19. And for that matter, it's great for your staff to also be aware of your protocols. Now, the third thing is that a lot of people said, hey, how about an informed consent document for our staff as well? And the answer is that's a bad idea. Your staff are covered by workers' compensation, and workers' compensation invalidates any defenses to liability. And that's legalese for meaning risk, accepting the risk here, it won't help you at all. They can't accept the risk of working for you or risk being fired. But what you can do is to go ahead and take all these great points that all the protocols you're going to put in place, make sure your staff are aware of those. And so that's frankly the best defense the doctor's company will agree with. It isn't the paperwork. It's number 1, not committing any malpractice, but number 2, putting the best infection control procedures in place possible. And that's what the rest of this webinar is all about, so listen up. Thanks, Bill.
Okay, thanks again, Bob. And everything Bob talked about is on the surgery.org resource page. You can access that directly from our homepage, surgery.org, and that has been really useful for people, so please check that out if you haven't done that. So next, I want to introduce the Grand Jefe, El Presidente, Mr. or Dr. Herlif Lund. Herlif, thanks so much, and I hope the early stages of the presidency have been going well for you. And Herlif is going to introduce some concepts, particularly just the position of the society on getting back to practice and elective surgery. Herlif, thanks again.
Thanks, Bill, and it's great to be on these webinars. Again, thank you, Sientra, for absolutely helping us in a critical time. I know I won't forget you, and I know our members aren't going to forget you. Just to refresh your memory, back on March 15, 2020, with the threat of the COVID-19 virus pandemic upon us, the Aesthetic Society issued a memo at that time stating our position was that all the members should, as soon as possible and as to the greatest extent possible, decrease their office activities, limit in person-to-person, patient-to-patient contact, and probably for most of you remember, is stop elective surgery. And this position was made based at the time on the recommendations of the Surgeon General, the CDC, the American College of Surgeons, and numerous other surgical and medical communities. And the Aesthetic Society debated long and hard. We understood the impact and challenges this was going to place upon our members, but at the time it was critical to say PPEs, and there was a lot of other critical medical supplies that we needed to do our part to take care of. Well, it's 6 weeks later, and as our intro music today said, everybody's wanting to get back in the saddle again, and the country is now reevaluating and reopening for business. And that includes easing restrictions on elective surgery and aesthetic medical procedures. The Aesthetic Society through its task force put together for the COVID-19 Safety Task Force, directed by Dr. James Fernau, who will be on this panel later, have been working incredibly diligently to develop guidelines for members to reopen their practices. And these guidelines are based upon current information, and it's the best current information we have. And again, concludes recommendations from the American College of Surgeons, CDC, NIH, Quad A, and on and on and on, literally dozens of other medical and scientific organizations with a lot of brain power. All the members, as Bob indicated, should have received by now the supplemental COVID-19 informed consent in your email boxes. And you should be able to download them and use them for your practices. We recommend that you use the supplemental consent, not just for your surgical patients, but every patient in your practice. For your follow-ups, for your patients who are going to be having injectables, and yes, your non-invasive medical spa patients, any patient who has potential to be a COVID-19 or be exposed to COVID-19 should sign that. And that means basically everybody. For those of you who haven't received your copy of your COVID-19 supplemental informed consent, or maybe just by accident, I'm sure, deleted it, as Bill said, you can access it on the Aesthetic Society webpage, which is surgery.org, COVID resource page on our website. The Aesthetic Society is also going to have out soon recommendations for reopening offices and resuming elective procedures. And these are designed to help our members reopen their practices and return to the operating room, with the emphasis on maximizing safety for our patients, our staffs, and let's face it, for us also, we're the surgeons. And these recommendations, I emphasize, are not mandatory. They do not establish a new standard of care. These guidelines, though, have enough latitude built into them to handle different various regional, state, and city variations that are due to different testing capabilities, the prevalence of COVID-19 in your community, and the availability of community medical resources. And these recommendations are fluid. They're going to change as our knowledge base improves on COVID-19, as the testing quality and availability improves, and as more resources and for essential PPE become available. The Aesthetic Society's COVID-19 Safety Task Force will be making updates on their recommendations, and they'll be presented in future webinars. They'll also be presented in emails that you'll be receiving. You'll also see articles showing up in the ASJ, the Aesthetic Surgical Journal, and also in ASN, the Aesthetic Society News. We will stay true to our mission. I'm going to read this little quote out of it: to advance the science, art, and safe practices of aesthetic plastic surgery and cosmetic medicine. The Aesthetic Society does recognize it's been a very difficult time for our members, and our goal is to help you in every manner to get back into your office, back into your ORs, back into the saddle again, and to do it as safely as possible. I am going to be on the panel later today for the Q&A. If you have any questions, please feel free to send them in. Also, you can certainly reach me through the Aesthetic Society. Every morning I get a stack of emails, and I'm very happy to look at them and answer them if I can. And I'll turn it back over to you, Jim.
All right, Herlif, thanks so much. And we're going to go directly now to Jim Fernau, who's the chair of the Aesthetic Society COVID Task Force. And Jim's going to give us a report on kind of the summary findings of the task force. So Jim, take it away, and after that, we'll resume some Q&A.
Okay, thank you, Bill. Can everybody hear me?
Yep.
All right. Thank you, Bill. Thank you, Dr. Lund, and thank you, Blaine. So our general considerations and gating criteria, we're looking for a 14-day downward trend in the number of cases and deaths in our region. And this should begin when a 3-day rolling average shows a downward trend. You got to know your local hospital current circumstances, whether hospital beds, ICU beds, ventilators available, staff capacity in your office or clinic, surgery center, hospital. Know the COVID-19 testing capacity and capabilities at all levels, hospital, Quest, your office. And our facilities and office must have a transfer policy for the hospitals to receive problem patients. So I really want to emphasize virtual consults and telemedicine. Patient portals, we can gain information before they come in. Forms, screening questionnaires, especially the COVID-19 screening questionnaire, fee collection, co-pays, consults. We want to avoid the exchange of money. COVID-19 consent form, which was beautifully manifested by Bob Aicher. Want to remind them of social distancing and the COVID-19 education. This could be in a form, anything you can do to for your patients to educate them. Ask them to wear their own mask to the office. These are recommendations only. A 1.5% hydrogen peroxide mouthwash before they come. This is from the ADA. And Lysol disinfectant to their shoes. My patients have been very receptive to this because of many things they see on the internet. Have them record their temperature twice a day for a minimum of 2 weeks and look for trends. Sometimes they're 96 to 97, and when they start to hover even around 99, that could be a problem. Have them keep a log of their temperatures, and of course 100 degrees is the temperature that the CDC is giving a warning sign. So after exposure, there's a 2 to 14 day when people are going to exhibit symptoms, fever, cough, a loss of taste or smell in 70%, which is an early sign. Shortness of breath is a late sign. Loss of appetite, extreme fatigue, conjunctivitis in 40% as illustrated here, mucus or phlegm, and muscle aches and pains in 23%. COVID toes, which are a bluish discoloration or blisters, and this is an early sign. This is not a late sign. Sore throat, headache, chills. I want to emphasize repeated shaking chills, a new sign by the CDC. Stuffy nose, nausea and vomiting, diarrhea. And screen for comorbid conditions. Age greater than 65, even though they think they might be okay, they're still at higher risk. Hypertension, obesity, diabetes, COPD, asthma, immunocompromised patient. Seek immediate medical attention if there's trouble breathing, persistent pain or pressure in the chest, new confusion or inability to arouse, especially in those patients over 65, and a bluish lips or face. Encourage the staff to view webinars, and we can send those to them in email form, and encourage a Zoom or similar meeting format with all of your staff even before they come in, and have the staff review the COVID-19 consent form that Bob Aicher constructed. I think that's very important for the staff to know that consent form so that they can better communicate with patients. Wear eyeglasses instead of contacts. Have the staff record their temperatures at least once a day. Clean each room between patients. Have the staff put away their cell phones or sanitize them. This is an ultraviolet light sanitizer. Designate areas for donning and doffing and disposal of PPE. And this is from the CDC, a way to actually put the gown on, affix your mask or respirator. The goggles or face shield are extremely important for those of us in the back and the actual clinical situation, and gloves, and use the safe work practices to protect yourself and limit the spread of contamination. Before opening, consider a deep cleaning or an HVAC company like Bactronics. This can be somewhere between 51 cents per square foot. Next week, it's costing me something like $2,500 to have my entire office and office surgery center decontaminated. Check your state and local guidelines, including a public health director. Restart all of your services and check your PPE supplies, masks, face shields, gloves, gowns, shoe and hair covers, hand sanitizer, Lysol. Front staff, ear loop masks, cover gowns, gloves, eye protection, wear scrubs. Clinical staff, N95 masks, face gloves, cover gowns, hair coverings, and scrubs for the entire staff, and make sure they're freshly laundered. So in surgery, you could wear a mask on the left. It cannot have the respirator valve on the right. If you're performing office procedures, that respirator valve is probably okay. This is a photograph of the real N95 1860 respirator surgical mask. The key features, this is FDA cleared for a surgical mask, and it is designed for the fit test. The fit test is a little bit complex, and I put a few slides on here, and you can go to osha.gov for a full explanation. You want to have Lysol or similar disinfectant to spray shoes, surfaces, etc. 70% isopropyl alcohol in spray bottles to clean contact surfaces, and hand sanitizer. Of course, we're all familiar with Purell, but Sterilium and Avogard can be ordered, and there's a little advantage because a lot of people don't know about that. So that's a great pearl to know about. You want to acquire your PPE as soon as possible. Start it now. It may take 4 to 8 weeks. Consider reusable fabric gowns. And remember, many PPE are from China, and some of these K95 masks do not meet standards that are set forth by the CDC and OSHA. On day one, make sure there's placards that the patients can read. Make them comfortable. This room has been clean and disinfected, and have the patient see the staff actively cleaning. On your first day, you could possibly recommend no patients on the first day. Have a very relaxed atmosphere for your staff, kind of a Zen atmosphere. Delineate specified cleaning duties. Make it easier to clean the contact surfaces by removing out all unnecessary magazines and brochures, and make sure your office is meticulously organized and cleaned. So we want to change it from something from the before to the after and make everybody and your staff feel comfortable. There's a next slide before that, please. Great. So concept of one patient at a time, a no waiting room. That original waiting room now becomes a beautiful walk-through reception room, a text notification of the patient to be seen. Even consider a texting service. We want to minimize traffic. We did a task force poll of our members. The number of patients at any one time in the office, 1 to 4 is most common, with 7 being the highest, of course, according to the number of examination rooms and the people you have on staff. Have a risk assessment available. A mild patient could be asymptomatic with no contacts. A moderate risk might be a first-line healthcare worker, first responder, grocery store worker, especially if they're giving a history of they had no PPE, no masks, etc. And a severe risk would be something that's symptomatic or positive. So if they're coming in for Botox and fillers and they're low risk, without the signs or symptoms, a recommendation only, not a prescription, just maybe shower with baby physoderm on their hair, face, and neck before they come. Use HIPAA cleanse from the neck down immediately before the appointment. Consider 1.5% peroxide gargles. This is by the American Dental Association. Do this at home. and administered just before Botox, fillers, especially lip augmentation. Consider a suction aspirator, which is applied by the mouth during the lip augmentation, and air purifiers in the exam rooms. Here's an example in a lip augmentation. We could have them gargle with 1.5% hydrogen peroxide, add that suction evacuator held by the nurse, and we could inject their lip with their mask off. This is just an example. Surgery. This is a complex issue, too involved for me to explain here. Follow your local and state regulations, review Quad A guidelines, and follow your specific local surgical center and hospital guidelines. For example, in Pittsburgh, May 11th, we're opening up for elective surgery, and there is mandatory COVID-19 testing for all elective procedures. Post-procedure, virtual consults for the checks, sutures, absorbable when applicable. If you're not comfortable, use your 5/0 and 6/0 nylon and remove those when appropriate. And then consider deep sutures with tissue glue, minimize drains if possible. And we might have to encourage self-quarantine for 7 to 14 days for those patients and their caretaker with larger procedures. Monitor. Have the patients monitor their temperatures and their symptoms, those potential symptoms we gave out, and log that daily. If a patient or staff would test positive after the procedure, they need to be immediately referred to infectious disease, which we will have contact and communication with before all of this, and then the entire staff will have to be evaluated appropriately. We are not experts. We need to delineate this to the experts. Testing, the basics. PCR test, or the RT-PCR, reverse transcription polymerase chain reaction. This test for viral RNA and genome material. This is currently the gold standard. It can be a swab or sputum test compared to antibody testing, which is a blood test, a pinprick test. This test for IgM or IgG antibodies to something. It could be non-COVID. It could be SARS-1 coronavirus. It has to do with the N protein and the S protein. This is non-standardized, qualitative only, no titers done. We don't know which antibodies, if any, are protective at this point or for how long. It's easier to collect than the other ones. So the PCR test has a very low positive rate. Negative test, however, does not preclude infection due to sampling error and viral migration over the course of the infection. This is good for acute phase diagnosis and our pre-surgical clearance. That's important. The antibody testing can take 2 to 3 weeks to turn positive after exposure. False negatives are common, especially early on. False positives can give a false sense of security. There are lots of poor quality tests out there. At this point, non-standardization is hard to interpret. This is good for epidemiology, convalescent plasma donor, screening, and late diagnosis in PCR negative patients. So, expert recommendations at this point on this date in time. This is recommended by the World Health Organization, the CDC, the Infectious Disease Society of America, the American Society of Clinical Pathologists. And that reminds me, call your local pathologist, get their recommendations. The American Medical Association and LabCorp, antibody testing. This is blood testing, fingertip testing, recommended for diagnosis by, well, companies that sell a test. Possible role, if combined with PCR, stay tuned. It could be up to a 90% correlation. I want to thank you all for your attention. And this is Steamboat, the horse from Wyoming, and hopefully we'll all be
back. Thank you, Jim. So I just want to make sure everybody knows. so that, Jim, that's kind of summary of the task force recommendations, but you had lots of different points in there, and I know that that'll all end up being published on our resource page where people can refer to it. But those are basically recommendations. Those aren't rote things that absolutely people are telling people to follow. Those are things people can consider and then certainly take in their state regulations. Correct?
Exactly, Bill. This is not a definitive prescription. These are recommendations.
Great. Okay, well, thanks again, and we'll have more to say in the discussion. So I'm going to go to Brad Calabrese now. So Brad, Brad, you have over 70 employees, and we all talk about, you're ready to get back to business and opening up, but I think you have some things to share with us in terms of just some things that getting back, maybe challenges that we haven't thought of. So we've asked you to kind of share some of those and kind of talk just briefly about a few of those things. So thanks again.
Yeah, thanks. Well, I think that the point was that, over the last few weeks, we were thinking we were doing everything to prepare for this and all the sort of things that Jim went over and how we prepare the office. And then as you really get into it and you get back into the office and you're planning surgery, there's a lot to do. And, I think a lot of concern from employees, which I wasn't expecting. So I think maybe that pre-warning to all this, surgeons listening is to start thinking about how you're going to have the dialogue, start communicating with your team about who's feeling comfortable, start working through some of their fears right off the bat. So you know where they are and when you expect them to come back. As it relates to that. And I think that was one of the most important things because everybody seemed great until it was time to come back. And then all of a sudden we started to have fears. So we started doing some more Zoom meetings with our different parts of our teams. And we're going to do an office-wide Zoom meeting tomorrow at 3, just to really get everybody in key. I also agree that as we brought people back this week, that they feel better once they're here. So I do think it's best to bring the team back and not have patients initially, let them feel comfortable with the system and all the things that we do to keep everybody safe, make sure they know how to use PPE appropriately, and that they know our screening techniques, both on the phone as well as when they get to the office. So it's those sort of things that I think that are, I would just want to have everybody be prepared for as they step into this and give themselves enough time, calling everybody back and getting the schedule going and getting pre-ops done and the OR done and getting, if you're going to do testing, how you're going to do the testing and get that arranged. There's just a lot to put together, so they could start that now in the next couple of weeks. As they get closer to coming back online, usually the state government then becomes more clear about what they're requiring or what they're recommending as they step back into it. So until that, our state, at least my governor, didn't say much until he said, okay, on this date, you can start doing elective surgery. Then they started to give us more information about what that looked like at that time. So I think if somebody hasn't gone back yet, they'll get more information as they get closer.
And Brad, you had told me about some challenges that you have with some of your employees in terms of maybe some apprehension about doing certain types of injections. How have you handled that?
Yeah, so I have 3 nurse practitioners as well as my other injectors, and so they were fine doing Botox because they could leave the mask on them, but anything that required taking the mask off, and I was like, and so that's like everything but Botox, because all the lasers, all the fillers, all the almost everything was that. So I wanted to reassure them that they understood the protection that they get from like an N95 mask and a shield versus them being in a regular cloth mask and somebody else in a cloth mask at a grocery store, right? That's this, the virus is everywhere, and that we can make an environment in the office where I think ultimately they're actually the safest place then, because they are completely prepared and they have all the safety in them. And so we really reiterated that to make sure they understood what N95s and all the things we're doing, and that questionnaire to make sure people that are sick, that questionnaire is really important because you can start to identify a lot of people who maybe shouldn't be in the office. So you're bringing in a safer group of people in the first place, and then that they're safe with all of our protection and all of our PPE.
Okay. All right. So let's just talk a little bit about testing. And I wanted to kind of go back to Jim. You kind of started with this, and, there's different tests out there. You've kind of explained that between the PCR RNA test and the antibody test. But I think some of the confusion is there's now 80 plus tests that are, some are rapid tests, some are more quicker turnaround time. And I think that's what you were referring to. Brannon, Claytor, who's on the task force. We've talked about, you have those things as kind of like Excel for dummies, not that plastic surgeons are dummies, but really testing for plastic surgeons. Can you put it in simple terms and turn it just like a 101 class? And specifically, even I was telling someone this morning, even the CDC test, which from a month ago, which was the only test being done in the United States and had to be sent to the CDC, that was found to have 35% false negatives. So, there's not a lot we don't know about these tests, but can you kind of just give a little bit of an overview for simple terms for people to understand these tests better?
Bill, thanks so much. I think that Jim did an extremely good job going over it, which basically boils down to serology tests or the antibody tests may eventually be very helpful, but at this time, there's just way too much confusion. There's no standard monoclonal antibody standard for all these different companies to compare against, and therefore there's no comparison between these results. Early results may not have identified an antibody, and late results may actually be picking up common flu viruses. So at this stage, for epidemiological studies, antibody serology tests are helpful, but they're not helpful to us at all in our practices. The PCR tests, the ones that were taking 7 days when this all started, and that have now shortened down to a couple hours at hospitals and testing centers, are definitely the gold standard. Increased testing capacity with home tests that you swab your nose yourself and you send it in, or a spit test, are going to definitely give us increased capacity in our offices to be able to test these patients that we want to bring in and do certain procedures on. And so ultimately, we will find more and more PCR tests coming online. So it's PCR tests for now, serology tests for academics.
So back to the PCR test, though, there's a lot of these that are new, and a lot of these are not really validated either yet. So how does somebody decide if they want to do a PCR test? How do they decide which one to do?
That's an extremely good question. First thing you need to look and see, has the FDA granted emergency use authorization? If they've done that, then you've already got the FDA's, if you will, stamp of approval on it, which gives you a lot more comfort in putting validity in those results. And so then the next thing you look at is you break into the actual product brochure and look down and see how those different tests compare to the gold standard tests. And they will be putting that information in there. And that's something that you can go and investigate yourself and then go back on and say, based on this test is much more valuable and valid.
Okay. Louis Rios, president of ASERV, also president of the Texas Society of Plastic Surgery. Louis, I know that you came on a webinar, our last webinar, I think, and we had an infectious disease doctor on and talked about a little bit about testing. I know you've done a lot more research into that, but also maybe some comments in terms of other things that are relevant to this conversation and back to practice.
Right. So I think that when we talk about testing, sometimes we tend to just focus on testing. And I think Brad was hitting the nail on the head about, having a safe environment. When we talk about testing, you just look at testing. You got to remember that, there's an availability of the test. Some places are going to have access to testing, PCR, some aren't. There's also the issue of accuracy. These tests aren't accurate. Even PCR tests are not accurate. So we don't really have a great accurate test like we do with like a pregnancy test, where someone can come in that day, that morning, get a pregnancy test, and you're 99.5% sure they're not pregnant. We don't have that for this yet. Okay. And maybe we'll get that in the future, but we all need to understand that if we're just focusing on the tests, it's not even coming close to like a pregnancy test, right? Because there's always a lag before and a lag after, right? You can take a PCR test today or an immune test today, and maybe you were exposed yesterday and it's not going to show up. So there's always this issue of a lag before the test and after the test. So we just don't have like that accurate urine pregnancy test that we're used to help us out. So what that means then is we can't just focus on the testing. We got to focus on a whole strategy, kind of what Brad was talking about with the staff. And so if you can employ testing, take a look at what tests are available, see how they can be logically used in your whole algorithm, if they're available. And then you've got to do, you got to use your PPE, you got to have some office policy and procedure manuals, you got to have protocols, safety protocols, all that has to be wrapped in together so that you can have a safe environment. So, sometimes we're just concentrating so much on the tests that we need to consider all this. So, things like screening questionnaires are important, temperature checks are important. And then just figuring out how the test is logically going to fit in. Now, we've been developing an app, a breast implant app over here with the Society and Aicher, and we've kind of we're turning it into a COVID app. And so we're hoping to download, for example, screening questionnaires and consents and all that, so that maybe as states open up, our society members might be able to download that app and have all those tools on there to document and to maybe make the process a little bit more streamlined. And we might actually even be able to collect data as well as we roll out the app. So I would agree with Brad, we got to have all these processes, and I would agree with him too. Like, I started injecting this last week and we just went slow, and we just started implementing all our processes. And now my staff is getting a little bit more comfortable, and we're speeding up a little bit. I mean, we're not going full guns ahead, but, we're starting to see a little bit more patience. Now my staff feels the confidence, they've signed off on a policy and procedure manual, not on a consent, excusing me of any blame, but more on a policy and procedure manual stating these are the protocols we're following, that they need to follow the protocols, that they need to do their temperatures in the morning, that they need to. And so, it's kind of a process you got to roll out a little bit at a time, and then you'll get faster and you'll get better at it. And then your office will change, and it's gonna have this COVID type of protection probably for at least the next few months.
Could I step in here for a second and just add something? I think this goes back to borrow a term from Mark Jewell, one of our past presidents. We had a time of culture of safety we talked about. And really, you want to engage and make your staff also participants in that culture. They should be feeling like they're actually helping out, and they're actually stepping in and engaging in making the office and the practice safer. If you just dictate to them, then you don't get the response. You've got to get them to buy into the process. And that takes time. And you can't do it by just opening your office on Monday and say, everyone show up a half hour early on Monday morning, and we're going to go through this. It won't work. You'll have a complete colossal failure. So what Dr. Rios said, what Brad was saying is, plan to, if you're going to bring your practice back, plan to have them come back in at least, a number of days before and do dry runs, but also ask them to look for where you have not picked up on something. Look for flaws that you overlook, because, it's like everything else in the operating room. We all have everyone look from the right, the left, and the middle when you're doing a breast dog, just to make sure one's higher than the other, you didn't miss something. Same thing here. Use your staff. They're willing to help you. They want to be engaged in it.
Yeah, it makes complete sense. Similar to clinically, we know patient education has been really important in terms of optimizing outcomes, and so this is really educating your staff and getting them to really be active participants. So I think that's a great point.
Bill, that was part of it. I got feedback from some of my staff as I was talking to them about things they were worried about. And so we started to add some things to it. Like we did order plexiglass to put in the little portable ones, because I could watch my team, because, they're really only about 3 feet and they're sort of down below from where the patients are standing there. And I could see them really backing up and being a little cautious. And so what I didn't think I was going to do, I decided to do, because it's cheap and it's not expensive. And then also they were really worried about filtration in the room, the air filter and that sort of thing. I was able to get really good ones with UV light too for like $50 or $60 a place. Was I really going to do that? Not necessarily, but if for $50, $60 a room, if it made my team feel better, then you can add some things like that to make them really believe that you're listening to them and you're trying to do something to make them feel safer. And that's why I did it.
So, Brad, just a follow-up question for you. We tend to focus more on patient testing, but how about, what's your feeling in terms of staff testing? Is that something that you're thinking about, and what's your position on that?
Yeah, so it's a hard one. I think a long time ago, thought I would just test everybody, but I'm not going to. But we have the availability through Quest to get a IgG test if they want it. So I've left it to our employees who want to get tested. They use their insurance. We will draw the blood and send it in and send the requisition in for them. Because some of my team feels like they maybe had it and they felt like they had symptoms and they kind of got through it, but they're not sure. And so if they're interested in it and want to know, then we will go ahead and do that for them. It's through their insurance. It's their obligation, but we'll make it easy for them to do that. But I'm not going to require it from anybody.
And Jim, for now, how about the task force? What was y'all's feeling on staff testing?
I think that if it's available and we can do it, we're going to do it. For example, I did order tests from 2 testing companies for home testing, and I'm going to test all of my staff and myself, and they are very excited about that. I think many people have said this already. The staff is the most nervous about coming back. My patients are clamoring to come in and get their Botox and get their filler. The staff is what I'm really concerned about. And I want to make sure that they are 100% comfortable with coming back. And I want to pay them for my PPP. I want to give them paychecks, and I'm excited for the whole process. And I want them to feel comfortable.
And I just feel like I need to say something about that too, though. I just want to make sure that when we think about the antibody test, and you mentioned this, but I just want to reiterate it. So it can give a false sense of security to them if they say, oh, look, I'm IgG positive, but there's some false positives there because some of these tests, so you have to know what test you're looking at, because you can get a cross-reactivity to a previous coronavirus cold or something, and it will say, yeah, you've been exposed and now you're immune, but it really wasn't to COVID-19. So I think that wouldn't want them to step away from all the safety things they would do to protect them and the patients, just in case it was a false. So the antibody test has problems with it, and so it may make them feel better, but still go back to doing everything that you actually do in the office because of that uncertainty.
Yeah, and I think the educational piece for that is probably just like the flu. You get the flu vaccine or you get the flu, but it doesn't mean the next year you can't get the flu again. So it's
right.
Something people understand and can relate to. Jim, just another quick question for you. Back to the staff. So if a staff member is diagnosed with COVID, when can they return to work? What's your feeling on that?
Well, I'm going to refer to my infectious disease. I've already have communication with them and what to do. And he said, don't worry, we'll come up with a plan. But initially, let's just say I'm at work next week and somebody's positive. Obviously, I'm sending them home and they're going to get tested and we're going to get the consult. And then we're going to have to look at the entirety of the staff. What are we going to do? And so I'm going to rely upon the experts to help me out. I think it's a very difficult question and a great one, Bill. That's a great question.
In the state of Kentucky, they've said sort of what you do in that situation, and what you do is it has 4 items to it, in which basically it is that you have to have not had a fever for 3 days, and then you have to be 10 days from the onset of when you started to have symptoms associated with it, and you have to be medically improving and getting better and doing better, and then you have to wear a mask and you can come back to work at that point in time. So those are the requirements after testing or being exposed, or where you think that you've been sick, even if it's not a positive test. Those are requirements to come back to work, and you come back with a mask.
Okay, this is a question out to the group. Re-sterilization or reprocessing of N95 masks. Those are in limited supply. People are using them in their offices. Does anybody have any input to that, to our attendees?
I've got some UV boxes, in my spa, so we're throwing ours inside the UV box.
At the hospital.
Yeah, thanks, Bill. I think that Luis's suggestion is a very good one. Certainly the hospitals are setting the standard for this, and I would check with your hospital, because perhaps you could dovetail into their utilization for re-sterilizing masks as well. But certainly UV light is going to be extremely helpful in mitigating any kind of virus that may be on that mask.
So, actually, Craig. Craig Kreisman, who is a member, just told me today about some information. If somebody can mute their microphone, because we're getting a bad echo. So, just time can also, masks that are in the office, you can assign your employee a mask and they can use it that day. The one thing you want to do is make sure they're not touching the mask, or certainly they wash their hands after they handle the mask, or Purell their hands. But then that mask can be put in a paper bag, and the amount of time it needs to sit in a breathable container is about 72 hours for all the particles to, the viral particles to basically die. So, you know, for example, if you have somebody that works 5 days a week, you give them one mask for each day of the week. They put it in a paper bag and it sits for the next week. And so that is one way, and that's actually recognized by both the CDC and FDA as a way to reuse masks.
And that's how we're doing it, Bill. Exactly.
Can I bring up one thing about the ultraviolet light? And it was a study done here in St. Louis, and ultraviolet light cleansing isn't going to work for most of it. And the problem is, it's the particulate matter in the air interferes with the effectiveness of the ultraviolet light. And there's a device that is being tested down at WashU and SLU and that, where they can, what they're doing is they can sterilize in 10 minutes, 100 N95 masks. It is ultraviolet light, but it's attached to a vacuum. And the vacuum removes every air, all the particulate matters out of it completely. And then they can do the, and it kills it in 10 minutes. So it is something I think you're going to see showing up in the community everywhere. But if you're using and relying on just ultraviolet light without removing the particulate matter in it, you're probably not really sterilizing that mask.
Yeah, that's a good point, Herlif. You know, and there's certainly other processes too, moist heat, dry heat. There's also peroxide type washes that are being looked at. I think Steris has even been mentioned. And you can look at these different things, but in terms of certainly things that are available at somebody's office, those may be more limited. Okay, I have another question. I'm going to ask Louis Rios to start with this one. How about, Louis, can you talk about the relative risk of patients that we're seeing? Because given patients and their occupations will have different relative risks of being exposed to a virus. For example, I think the highest profession is a dental hygienist. And then somebody would say it would be a very low one, would be like a financial person or an accountant. But do you have any sense for, would you change your protocol, for example, based on the type patient you're treating?
Yeah, I think especially when you're opening up, I've given a screening questionnaire, and kind of connected that to a classification system of a low risk, medium risk, high risk patient. And obviously we want to kind of stay more with the low risk when we're starting out. We're using our protocols until we get a little bit more comfortable. So like you're saying, a high risk patient, someone who's treating someone with COVID-19 or they have COVID, they're not coming in the office, period. A low risk patient, like what you're saying, someone who had minimal risk, maybe isn't in an occupation that's been exposed to COVID, we're kind of bringing those in at first. So I think it really helps at the beginning. And then I think once you get into the moderate risk patient, then that's where you're thinking about what type of procedure are you doing. So, you know, if you're going to do a lip injection, you better make sure that your nurse injectors have adequate PPE, they have N95 masks, they've got face shields. And so I think that's how you can kind of, you know, start. So start off as much as you can with low risk patients to get your protocols done. Then, you know, start looking at the procedures, your PPE, you know, and the risk of the patient, and start matching those all together and get a game plan.
Yeah, those are good comments. Jamil, I just want to have you come up. I know you're gonna make some comments at the end, but were there any questions that you've seen from our attendees that would be good to get answered before we need to wrap up?
You know, I think it's a lot of common questions that people were talking about, and we've covered a lot. I think we've discussed about the potential to use testing. I think the most important thing that people need to take away from this is these are suggestions, okay? And you have to take into consideration your state, your local, and even your institutional capacity and policies and regulations to do this. Okay, this is information for us to think about, to consider, but it has to be within line of local governance. Okay. And as we all know, testing, the ability to get a PCR, so a nasal swab test, varies dramatically even within certain states. So we have to keep that in mind. Now, one other thing I see commonly that comes up in discussion, even beyond this webinar, is we get this term asymptomatic patient thrown out very commonly, or an asymptomatic COVID positive patient. Now, it's very important to differentiate between two types of asymptomatic patients. So the patient who's positive that is truly asymptomatic, never has any symptoms. And then there's the patient who is positive that is in the incubation period before they... Anna, you can mute yourself. Great, thank you. So there's a patient who's in the incubation period who's positive, and they're two different things. So far, the literature on the truly asymptomatic patient, the literature about them being able to transmit is limited. Okay, so a truly asymptomatic COVID positive person, we don't know if they can transmit. I think the ones that we're really concerned about are the ones that end up developing symptoms and testing positive, and that we miss out in that small window prior to that, whether that's 2 to 5, even up to 15 days, but the mean and median is about 5 days. So I think what we have to also consider then is, even if you are testing PCR, that there is a window in the incubation period where they may not have symptoms, and they may also test negative. So even if you're testing, it should not give you a false sense of security that you can let your guard down. And that's probably the most important thing, okay?
Yeah, you know, and I think I've just done some chats that I've been on. There are people that are just concerned about that asymptomatic patient, and if they have, for example, general anesthesia, are they going to be more prone to a problem? And you know, some good news has come out that's been shared on some of these chats is there's some actually good studies now that correlates the viral load with the severity of disease. And so people with low viral loads tend to have more asymptomatic cases or minimal disease. And so those patients are typically less likely to progress on to problematic either outcomes or courses of the disease. So, well, listen, I'm going to go back to Jamil just for a wrap up, and I'd like to thank all the panel for all their contributions. It's been great. Jamil, I want to congratulate you for the aesthetic meeting 2020 at home, which was this past Saturday. You did an incredible job, 1,300 people. I think the feedback has been excellent, so congratulations on that. And I know you're going to share with the attendees now how they're going to go to the next step, which is the on-demand content and the 37 hours of CME that is available. So congratulations again.
Yeah, thanks so much, Bill. And I think really the correct statement is we did a fantastic job. Bill was in the background as much as I was helping to put this all together. And we have the best staff of any professional society with Sue Dykema, you know, Tiffany. So when you see all of our staff the next time we get together, be sure to thank them for this. I want to thank all of you, our members, who were able to take time out on your Saturday to participate. I think the content was great. Now, you'll be glad to know that the 6 hours CME credit that you got for the Saturday, you'll have access for free to the other 6 hours, so the other 2 mini symposium, and that should launch around the week of May 11th on demand. What's also going to be great is that our instructional courses, they're between 1 and 2 hours. They cover, essentially there's courses on all areas of aesthetic surgery. There's going to be 16. They're going to launch, I think, this coming Monday. And for members, it ends up being something like $35 for 1 CME credit. The content is fantastic. So I'd encourage any of you who want to learn, who want to get your CME, these are great courses. So be sure to check in with the society on Monday or Tuesday, and they'll be up and you can do them on your own time. They're going to be available for the next few months. And then the following Monday, you'll have free access as a member to the other courses. So it's fantastic. And again, I want to thank Bill, my best buddy here in planning education, and all of the people that took time to pre-record, all of our faculty, and then also our Aesthetic Society staff who are fantastic, who helped to get this all together within 2 weeks, which is incredible.
Well, thank you so much, Jamil. And we want to thank all of you for attending. We definitely are planning to do some more. We will make some announcements in the coming days about potential webinars. We're planning a staff webinar, something for your staff, and we hope to have that next week, but details will be forthcoming. Additional information also on the resource page is likely to be provided as our task force comes out with their formal recommendations. So thanks again for attending. Certainly a shout out to Blaine Hamilton and Sientra for, again, all their support. And as all you are starting to get back to practice, please be safe, and we wish you the best luck, and we're going to try to provide you as much information as we can. So have a great day, and we'll talk to you soon.